Well, good morning. So as the panelists are taking their seats, first of all, I want to thank Colleen for the invitation to moderate this panel. I'm delighted to kick off the what's sure to be a great day today. And this first panel, I think, is particularly interesting. The title is Regulating Safety and Quality. We touched on these issues a little bit last night in the introductory panel. But we're going to dive into these in substantially more detail. So some of the things that we're going to be talking about over the course of the next hour and a bit is what level of regulation is appropriate in AI, what is the role of regulatory colleges in this matter, and how will we deal with patient complaints around AI technology when they inevitably arise. And finally, what is the FDA approach to safety and regulation in the US? So all interesting topics, and we have three terrific speakers. I'm just going to briefly introduce the three of them. In your packages, you have their full bios, or probably even that is only an excerpt of their bios. But let me just highlight a few things and tell you who they are. So our first speaker today will be Michael Froomkin. He is the Laurie Silvers and Mitchell Rubenstein Distinguished Professor of Law at the School of Law at the University of Miami. Professor Froomkin's research interests include AI and the professions, privacy, and other aspects of technology law. And he's the founder and editor of Jotwell, an online law journal, and a founder of the We Robot Conference. That sounds like an interesting one. Our second speaker is Vanessa Gruben. She's an associate professor of law here at the Center of Health Law Policy and Ethics at the University of Ottawa. Her research focuses on regulation of assisted reproduction, the legal and ethical aspects of organ donation and transplantation, as well as the self-regulation of health professions. And finally, our third speaker is Nathan Cortez. You met him last night if you were at the panel. He is the Associate Dean for Research at SMU Dedman School of Law and the Gerald R. Ford Research Fellow, among a number of other accolades. He teaches and writes in the areas of health law, administrative law, and FDA law. His research focuses on emerging markets in healthcare and biotechnology. So, terrific panel assembled here. Each will speak for 12 to 15 minutes or thereabouts. Those are their instructions. We have a timekeeper somewhere. Is there? Right. So you will stand up at some point and stomp your feet if anyone goes on too long. If someone has an absolutely burning question after a panelist speaks, you can ask it. Otherwise, hold your questions until the end, because we will have about 20 minutes at the end for questions of all three panelists. And it's often interesting to get multiple viewpoints on the same question. So without further ado, I'm going to call up Michael Froomkin. You can do it wherever you like.
Hello, bonjour. C'est un grand honneur de participer aujourd'hui à ce programme si important et opportun. Je voudrais surtout remercier nos hôtes de l'Université d'Ottawa pour m'avoir invité. Et c'est un plaisir de me retrouver dans cet environnement bilingue qui me permet d'utiliser ce qui reste de ma langue maternelle. Malheureusement, mon français technique est assez faible. Par exemple, j'ai dû consulter Google Translate, ou devrais-je dire Google Traduction, pour me rassurer comment dire AI, intelligence artificielle, et surtout machine learning. Ça m'a offert apprentissage automatique. Ensuite, ce dernier m'a fait penser à l'apprenti sorcier, une histoire qui offre une leçon qui n'est pas sans rapport à notre sujet, mais qui ferait l'objet d'un discours tout à fait différent de l'intervention plutôt technocratique que j'ai préparée pour ce matin. Je vous demande donc de me pardonner si je vous offre le reste de cette présentation en anglais, et j'espère sans vol de fantaisie. Soyez assurés que je vous êtes libre de poser des questions en français. So our topic this morning is how to regulate AI. Oh, ça alors. Vraiment. C'est exagéré. I stop now, yes? It's all downhill. So our topic is how to regulate AI for safety and quality. And for me, the question of how is first and foremost a question of who. Who should be making the decision about when regulation is needed and what that regulation should be? Now, the question of who arises in a very clear manner because absolutely everybody is getting into the AI Regulatory Act right now. There are international bodies, national bodies, subnational bodies, and international and professional private standards bodies, all busy issuing documents, standards, rules, and regulations. So at the international level, for example, the OECD just issued high-level standards. G7 did a document called Accountability in AI, promoting greater social trust. The EU Commission's put out ethics guidelines for trustworthy AI, and on and on and on. A recent study done by a Canadian think tank, CFAR, looked at national AI planning in the last 2 years, 2017 and 18, around the world, and found funded strategies in Canada and 6 other countries and the EU. It found national guiding documents with at least partial funding in China and 9 other countries, and it found national plans in progress in 15 more countries. So there's a lot going on. Now, notably missing from that list in that survey was the USA. The USA in Congress has got some bills, which have been proposed. Frankly, they're not very good. But that absence of the national official guidance hasn't stopped the White House from issuing a couple documents, and it certainly hasn't stopped the agencies from going ahead and regulating. So the FDA has been busy. The National Highway Transport Safety Administration, which we call NHTSA for short, has been busy. Many state-level bodies have been worrying about autonomous cars and making all sorts of rules, either legislatively or administratively. And of course, the Pentagon has been very, very busy. We must not forget, when we talk about these things, the enormous shadow of military applications of artificial intelligence in health and outside it. Meanwhile, national and international private standards bodies have been developing codes of professional ethics at a madcap rate. Existing professional bodies in the engineering side, like the IEEE, ANSI, and many others, have issued documents. Medical professional bodies, such as we heard yesterday, the AMA and the Royal Colleges, have also been busy. And indeed, the current landscape is of such a great profusion of ethical standards and guidance that a recent paper by Elisa Solo-Niederman, which actually presented at We Robot, which, by the way, will be in Ottawa next April, concludes that there are so many standards that a company can now cherry-pick whatever set of standards it likes to justify whatever it's doing, because there's so many out there. Now, my best guess as to what's going to happen, and the frame for what I'm going to be discussing in the few minutes that remain, is that while international bodies such as G7 and OECD will have some influence on national regulation, and treaties may cover a very small number of special cases in the near future. Certainly banning killer robots is my personal favorite, because armed robots with onboard AI and the possibility of autonomy and emergent behavior ought to worry anybody who's paying attention. But by and large, the real action is going to be at the national level, or in very special cases, subnational regulators. And they're going to be the main people involved in making rules. And so that's what I want to talk about. Now, if we look at all the various national activity, and especially the US case, which is the one I happen to know best, we do see considerable regulatory action. We see a lot of white papers, and we actually see the occasional regulation. But all this action raises a question as to what is the ideal approach for regulation. And I think it's very important for a group like this to understand that in this context, health AI is just one important, but just one part of a larger AI ecosystem, which includes autonomous vehicles, predictive profiling in multiple applications, immigration, law enforcement, sentencing, many other things, financial services, translation, marketing, and of course, military applications. So I have what I hope are 3 major takeaways for you today. And the first one is that any view on how to regulate health AI ought to fit into a more general theory of how to regulate AI broadly, or else it will not work intellectually, and more important, it is very unlikely to work politically. Yes, in some important ways, health is different, but also finance is different, and road safety is different. But in the case of AI regulation at a fundamental level, health is not as different as most people seem to think. And I'm going to argue to you, and here's major spoiler alert for major takeaway number 2, that the smart way to regulate AI, given these similarities and sometimes occasional differences, is that we should regulate primarily, but not uniquely, via sectoral regulation through existing agencies. Now, that may sound obvious, but actually there's a ton of scholarship in press right now which argues the exact opposite. A number of scholars are arguing that robots or AI present such unique issues like railroads, airlines, shipping, broadcast media, they should have their own bespoke regulator. For example, and he gave me permission to talk about his upcoming paper, Professor Lehman Wilzig of Bar-Ilan University, who has, I think, the distinction of being the first legal scholar ever to write about the regulation of AI back in 1981, has recently proposed that the U.S. should create a federal technology agency that would sit atop all existing technology regulatory agencies, would develop AI expertise in-house, and essentially take control of any AI-related regulatory issues encountered by those agencies. In his ideal scenario, he writes, "FETA is supreme but works with other agencies," unquote. And it imposes pre-deployment controls on all AI applications, much like the US FDA does for medical devices. Now, I happen to think this is completely unworkable for a large number of reasons. For one thing, politically, it's just way too much power in one agency. Other agencies, the existing agencies, have genuine, relevant expertise that ought to be respected and which ought not to be, we ought not to reinvent those wheels by trying to replicate them. And in the US, at least, the idea of a super regulator like that, with authority over the other agencies, is absolutely infeasible politically, if only because the various congressional committees and subcommittees will jealously guard their oversight jurisdiction and will not allow it to happen. So from a practical matter, it's a non-starter. Now this and several other rather slightly less absolutist positions are being floated by academics and think tanks all over the United States, and I wouldn't be surprised to hear in other countries as well, and they're driven by motivations which we should respect. One of them is the fear that AI is dangerous, maybe uniquely dangerous, but certainly dangerous. Second, that it's seen as opaque and capable of undermining accountability. And a third, which I'm sure brought many of you here, is the idea that AI is really posed for takeoff, and that it makes sense to try to get the regulatory structure right now before there's too large an installed base. And these proposals for an AI regulator do reflect some real features that make this a tough problem. AI expertise is rare, it's expensive, and it's not found in most agencies. There are indeed a small number of trans-substantive issues that are common to AI implementations and regulations, some of which probably are unique to AI. One of them is very data hungry, at least as we do through machine learning presently, and it's very subject to data quantity and data quality. Second is it has this black box characteristic that we've discussed. It's capable of autonomous behavior, and it threatens a lot of jobs at the national structural level, or at least, triggers restructuring where there may be very large skill mismatches, right? In the US, we have 800,000 truckers who don't have a lot of education. If autonomous vehicles take over their jobs, what are we going to do with them? There's a similar potential problem in health. What are we going to do with all the radiologists, right? And the dermatologists, when AI takes over the diagnostic part of their jobs? It's not all they do, but it's a very large part of what some of them do. Who's going to want to be a doctor going into those professions, and how are we going to handle the restructuring? Now, having said that, there are even more areas where the AI aspect of the problem, in my opinion, does not predominate. And one of them is privacy. Right? Many countries, especially the EU, have very strong privacy rules. I cannot imagine why we want to reinvent the wheel for AI rather than just have AI subject to the same privacy rules as everybody else. I would make the same argument for discrimination law. We have evolved quite strong theories of what is discrimination, how to identify it, what the remedies should be. Again, why reinvent that wheel? Let the experts deal with it. Discrimination, to me, is equally bad when done by people using new machines as when done by people not using machines. It's just the same thing, it's discrimination. You may need help in finding the evidence, but that's a technical problem, and I'm going to get to that in a second. I make the same argument, if time permitted, for torts, financial services, professional regulation generally, and for health. Because in this picture, health is just one of many sectors where regulators have substantial, specialized expertise. Unless we want to turn over pretty much the entire economy to one regulator, it's better to supply the missing piece of AI expertise to the existing agencies than try to restructure the whole system. So I propose two things. First is that the default is that AI matters are handled by sectoral agencies in the US for health, the FDA, which, by the way, is taking this seriously and doing an incredible intellectual job of specifying the issues, if perhaps not doing a brilliant job of writing out regulations, which may be more a political problem with the current administration than an intellectual or skills failure. We should use a specialist regulator only for the things where the AI aspect predominates over other aspects of the issues. For me, that's data, short-term job transition problems like we did with when all the industries moved to low-wage countries, and maybe that would include doctors, but maybe not, I don't know. But I wouldn't do it for things like funding, which ought to be part of a general package of STEM industrial policy, which ought to include nanotech, robots, biotechs, and other kinds of issues. I wouldn't do it for privacy, discrimination, or even the black box aspects of technologies. And here's major takeaway number 3, the last one, promise. What we need in government is a national think tank or professional core of experts who can be loaned out to agencies when they need it, who would have the common core of expertise. And we build something which is a cross in the US between the President's Council on Environmental Quality, which helps agencies do environmental impact statements, and the US Digital Service, which was this group of computer ninjas who sat in the executive office of the White House and were lent out to agencies to fix their public-facing web faces and interactive computer systems with the public. So you put something in the US in the executive office of the President, the agencies get to use it free so it doesn't hurt their budgets and they're encouraged to do it. You maximize the leverage of your limited number of valuable experts. And if you apply this framework to health and safety regulation, the FDA would be just one of the many agencies that would borrow this expertise when it needed. I'm going to skip ahead a little bit here. Now, some people say, but health is really different, right? In health, if you make mistakes, it can kill people. But that's true of airlines too. That's true of a lot of other things. In different industries, we make different safety innovation trade-offs, and that's legitimate. But that's something which the sectoral agencies are presumably the primary experts are dealing with. And there's absolutely no reason to think that an engineer trained in machine learning is going to be the kind of person we want making all those decisions and distinctions between what's the risk level appropriate in medicine, surgery, in financial services, or in sentencing, right? Those are really different activities that involve very different weighing and considerations, unless you want to take the view that I don't want to have any machines in anything, in which case you probably shouldn't be in this meeting anyway. Now, there are obviously some hard trouble cases, and I just want to mention these so you know that I'm not ignoring the hard cases, right? So issues of self-care, for example, home apps and devices with localized or remote AI-based smarts are a tough regulatory problem. But what makes this hard is it crosses into other areas of law, like unauthorized practice and consumer law, and maybe transnational issues. The hard things aren't actually the AI things, they're the other things. Indeed, just true generally of transnational issues, right? When you have export of care, or you have the problem that people may be wanting to test risky AI on vulnerable populations in the third world. A very tough problem because on the one hand, that's the natural market for self-care apps because they don't have access to medicine in lots of rural communities. On the other hand, they're not able to protect themselves and don't have national regulators maybe who are looking out for them. Again, those are tough issues, but they're not specifically AI issues. They're actually not that different from the issues of disposing of your trash in the third world. And I'd say the same thing about AI in the supply and education of doctors. That's really a jobs and market structuring problem and liability problem and a subsidy problem. And I'd say the same thing about AI liability rules, right? Liability rules are a very valid type of regulation, but fundamentally, if the machine's involved, we have some tough questions of assigning responsibility, but they aren't that different in the case of an autonomous car or a somewhat autonomous diagnostician. And we ought to have answers which are consistent across the realms. We're going to be in a very ugly place indeed. So to sum up, I think the smart first steps in AI regulation are to strengthen the sectoral regulators, not to try to lump everything into one giant regulator too quickly, to make an exception for the very small number of issues which are genuinely unique to AI, like data access, data quality, how you're going to parcel out access to databases or certify databases as trustworthy. In the case of Canada and countries with centralized health system, who's going to have access to the data that's collected by the national body? In the case of the US, it's going to be more of an IP focus as the data is very distributed and you've got to figure out ownership rules. And to build think tank capacity in government to coordinate among the agencies, provide technical support, and advise the regulators. Not apparently the fashionable view in legal academics today, but I think it's actually the practical and sensible one. Thank you very much. Merci.
Do you have a clicker? Is there a clicker? Here we are. There with the man with the clicker. Okay, any burning questions for Michael? Great. So on to our next speaker, Vanessa, please.
Who should be regulating and the how. And in particular, I'm going to focus on the role of regulatory colleges or self-regulation in terms of who should play an important role in regulating AI. There we go. Okay, so last night and today, I'm sure we'll be hearing lots more about the many different ways that AI and machine learning in healthcare is increasing. Whether it's by facilitating the work of health professionals or by substituting the work that they do, AI can and will be used for a range of purposes, such as predicting, diagnosing, and treating diseases. And so here are a few more flashy headlines to add to those stories. And so While the use of AI shows great promise to improve healthcare, as we discussed last night, there are risks associated with the use of AI, and inevitably there will be errors which will result in various harms. And those risks include a range of things: privacy protection, equitable access, and patient safety. And this morning I'm really going to focus on patient safety. And what happens when AI doesn't function properly and the result is harm to, or even death to, individual patients. So last night we spoke about some of the potential harms that might arise from the use of AI in healthcare, and I just want to reiterate a few of them. These are obviously not exhaustive, but they give us a sense of what some of the regulatory colleges might be faced with in terms of dealing with healthcare professionals and AI. So the first, of course, would be physical and psychological harms that are caused by AI. So, for example, where they're operating on incorrect data or biased data, or where they generate an incorrect outcome. More nefariously, they might be hacked, which might result in patient harm. There might be harms to patients when physicians fail to use AI properly. So there's a misuse of the algorithm or a misapplication of the technology. Or the physician might decide to override the AI. So we talked a little bit about this as well last night. What happens when there's a conflict between the diagnosis, for example, that AI makes and what the clinician thinks is going on. And the clinician may make an error by overriding the machine's diagnosis or decision. As we'll be talking about later today, many forms of AI are going to introduce a third party into the physician-patient relationship because of the use and reuse of data to support AI. And so there may be harm to patients as a result of that breach of privacy. And then, of course, there may be harms to patients where AI is used outside of the traditional therapeutic relationship, so outside of that traditional healthcare context. So, for example, through wearable devices or apps or that type of things, patients may suffer harm as a result of that. Okay. So in terms of regulating, who should be responsible and how? What are the best mechanisms for protecting and promoting patient safety? As Michael's just mentioned, there are many, many sources of regulation. And I just want to talk about a few of the national level possibilities in Canada in terms of regulators. So just to give a sense of the regulatory landscape and where self-regulation fits in that landscape. So of course, first and foremost would be the federal and provincial governments, external regulators. Health Canada at the federal level has the authority to regulate medical devices, and so it will have an important role to play, for example, in terms of setting national standards. Federal and provincial laws will play a critical role, for example, in terms of ensuring that privacy laws meet and are up to date when it comes to the protection of patient privacy when we're using AI in the healthcare context. Tort law, which is a fascinating topic, and unfortunately not something that I'm going to be focusing on this morning, is likely also going to play an important role when individual patients bring lawsuits against a variety of players, whether it's the healthcare professional, the hospital, the manufacturer, or the regulator itself. We'll certainly see some regulation in that sphere. And then finally is self-regulation. So self-regulation, this is where the government confers on healthcare professionals the authority to regulate members of their own profession. So by way of example, physicians in Ontario are governed by fellow physicians through the College of Physicians and Surgeons. Okay, and in fact, in Canada, self-regulation is one of the primary ways that healthcare professionals, most especially physicians, are regulated. So in some respects, the role of the regulatory colleges is quite limited, right? They have jurisdiction over the health professionals, not the technology or devices or the AI. And I think there's a temptation, therefore, to think that the colleges might not have a robust regulatory role in this space. But I would disagree with that. In my view, I think the colleges really need to take a proactive role in regulation. The colleges are going to have to deal with AI and machine learning in healthcare because patients who suffer harm as a result of these technologies are almost certainly going to bring a complaint to the regulatory colleges where a healthcare provider is involved, regardless of whether it's the AI, it's a content error, or a misuse. Patients will not be able to distinguish that, and in fact, as I'm going to talk about in a little bit, it's going to be difficult for the regulator to do that as well. And so I believe the colleges are going to see many complaints from individual patients. So rather than adopting a reactive stance to the regulation of AI, I think the colleges have to really take a proactive regulatory role. And in fact, I think that proactive approach is consistent with the historical foundations of self-regulation and its current statutory objectives. Okay, so a little bit about self-regulation, and then I'll dig into the details of how I think this might happen. So the right and obligation of self-regulation can be traced back to the 19th century, and it's really rooted in the social contract between physicians and the public. As Kruis and Kruis nicely explain, in return for a physician's commitment to altruistic service, a guarantee of professional competence, the demonstration of morality and integrity in their activities, and their agreement to address issues of social concern, society grants to both individual physicians and the profession considerable autonomy in practice, status in the community, financial rewards, and the privilege of self-regulation. And we see these captured, these historical roots of self-regulation reflected in the statutory frameworks that govern our regulatory colleges. The overarching objective in the statutes that govern self-regulatory bodies is to promote patient health and safety and to ensure that healthcare professionals are acting in the public interest. So they have a public interest mandate. And so to achieve that objective, the regulatory colleges have a variety of functions that allow them to do this. They license members, they set practice standards, they establish practice guidelines, they provide training and continuing education to their members, and they either provide remediation or in some cases discipline their members when they're not meeting the standards of the profession. And so proactive regulation in these various spheres, in my view, is consistent with the college's public interest mandate. Developing a rigorous and responsive regulatory framework to the use of AI by healthcare professionals, in my view, is going to go a long way to protecting individual patient safety and also in gaining public acceptance and trust of AI in healthcare. So before turning to the specifics, it's important that I acknowledge that there are important criticisms about self-regulation, okay? I'm touting all the wonderful benefits of self-regulation, but there are criticisms of this regulatory approach. These include that the way the colleges function are not sufficiently transparent, that the oversight of members are insufficient, that the complaint processes are overly onerous. And so I do want to acknowledge that there are these criticisms of self-regulation, but nevertheless, I do think the regulatory colleges have an important role to play. And so I'm going to look at three examples, three areas where I think the colleges could take some proactive steps to address AI in healthcare. The first is standard setting. Okay. So as I mentioned, the regulatory colleges have a role in setting practice standards. And these practice standards really articulate the criteria by which members have to meet in order to ensure that their patients are receiving high quality and safe health care. And self-regulating bodies are really well placed to do this. They have the expertise to set those standards and understand how members should be conducting themselves. They certainly have, in Ontario, an explicit mandate to do this with respect to technology. It's set out in the enabling legislation. And so in my view, the use of AI in healthcare really requires the colleges to update some existing standards and possibly create some new ones. So informed consent is an obvious one in this context. College policies and guidelines will need to be revised to reflect the type of information physicians need to provide to patients about the use of AI in healthcare. You know, this notion of how machine learning works, this black box concept, and that these technologies might not be explainable by physicians, or that the creators and developers hold the intellectual property for the AI, and therefore these conversations are going to be difficult between physicians and their patients, but it's really incumbent on the colleges to assist the physicians and set the standards for allowing them to do so. Some of the associations have already begun to help with these kinds of conversations. So, for example, the Canadian Association of Radiologists have developed a guideline that sets out the levels of autonomy for the AI system so that patients can better understand whether the AI is assisting the physician or it's substituting the physician's judgment. The college is likely going to need to develop some new standards as well. And we've talked about a few of these issues last night. One is what to do when there's a conflict between the diagnosis, for example, that the AI is making and a physician disagrees. The college is very well placed, in my view, to provide guidance to its members about how those types of problems should be resolved. The college is also well placed, for example, to tackle questions that arise when AI is used outside of the therapeutic relationship. So, for example, what's the physician's responsibility vis-a-vis a patient who is bringing in a swath of health information that's generated from a wearable device or an app? Should the physician try to interpret the data? Should she order new tests to replicate the data? Conversely, what responsibilities do physicians have to patients when they're recommending that they use mobile apps or devices? These are all things that I believe the college is well placed to set some standards on. A second core function is education. Education and training, of course, equip healthcare professionals with the knowledge and skills they need to practice their profession competently and to ensure that they're providing high-quality healthcare. And there's no question that healthcare providers are going to need to learn about AI. The extent to which they're going to need to do so is going to vary depending on their profession, whether they're a nurse or a respiratory technologist or a physician, but there's no question that they're going to need to have some basic education around these tools. And so I'd suggest that these are three areas where we'd want to provide some education to healthcare providers. The basics of how AI and machine learning in healthcare work, the benefits and risks associated with the use of AI, the risk of automation bias. This is something that we can get into a little bit more in the questions, but this is this well-documented phenomenon that when the human is trusting the machine more than they might trust themselves, that they might transfer that responsibility to the AI. They might be too trusting of the AI. And so it's important that healthcare providers are aware of that so that we hopefully can temper that risk. And then finally is who is responsible for harm. I think the colleges are, again, well placed to deal with this accountability question, and this is my last area where I think the college, as I say, is going to really need to wrestle with the regulation of AI and machine learning. There's various ways in which the college holds its members accountable, whether it's through things like spot audits, quality assurance programs, peer assessments, or registrar investigations. And the purpose of those programs is to provide feedback to their members. And so colleges are going to need the expertise to be able to spot audit their members who are using AI. But the other piece of accountability is the complaints process. It is inevitable that the colleges are going to see complaints around AI and machine learning. As far as I know, in Ontario, we haven't seen a complaint like this yet based on my research. But this is going to be a difficult task for the college to do. And that's because they're going to have to wrestle with this very difficult question about who is responsible when the use of AI in healthcare results in harm. Is it the manufacturer? Is it the physician? Is it the institution? It may be very difficult to distinguish whether it's the AI or the provider that's responsible for the harm, and the college is going to be placed in a situation where it's going to have to make some of these determinations. Okay, so what should the colleges do? So I think there's a number of things in terms of next steps that the colleges can undertake. First and foremost, I think the colleges need to start to develop expertise in this field, and where they're lacking in expertise, they need to bring in experts who work in this field. And so I think Michael has a great suggestion about this roving team of experts who can maybe help some of these agencies ramp up their expertise. The second is interprofessional collaboration. So a number of these problems and issues that I've highlighted are not going to simply apply to physicians or simply apply to nurses. They're common issues that are going to apply to many of the health professionals. In Ontario, for example, we have 36 regulated health professional colleges. It's critical that they work together as opposed to working individually. And so building these interprofessional collaborations is really critical in this space. And there's a history in Ontario of having done so. A number of the colleges came together to come up with guidance on better transparency. And then the final recommendation is coordinating and collaborating with other regulatory bodies. So as I highlighted at the outset, there are a number of regulatory players who each have their own specific regulatory jurisdiction. But ensuring that there's a coordinated approach across that regulatory landscape is really critical, and I think the colleges need to be participating in that. Thank you.
Let's move right on to Nathan.
And organizing such a wonderful conference. Great. Oh, great. All right. So I'm here to explain and take a deeper dive into the FDA's approach in the United States. And having looked at the vast majority of documents and regulatory actions the FDA has taken in digital health and artificial intelligence and machine learning, I think it does represent some important experiments in medical product regulation that we haven't seen in the United States. So let me begin by saying the FDA has a pretty thankless job. It's constantly told that it stifles innovation and that it impedes medical progress. So on the left is an article in Forbes, Why Apple Dumbs Down Your Smartphone. And on the right is a Wall Street Journal piece, Why Your Phone Isn't as Smart as It Could Be. And the author, if you haven't noticed yet, is Scott Gottlieb, who would later go on to become the FDA commissioner under President Trump. And the article captures this common sentiment that government regulation is antithetical to innovation. But as I mentioned last night, I recently came across this quote from another former FDA commissioner, Maggie Hamburg, which says it's not innovative if it doesn't work. And so I think one of the big questions hovering over these discussions is who's to say if it works or not? And this is something my co-panelists have addressed as well. Who's to say if something works? Is it the companies themselves? Do we trust the companies to just say, yes, it works, and provide data demonstrating that it works? Is it consumers? Do we trust consumers to evaluate these products? Do we use experience as our guide? When you look at other analogs in healthcare, I think it becomes clear that you can't rely only on companies to say that their products work. And you can't rely on consumers or even medical professionals to evaluate whether these things work. And so there's a reason we have agencies like the FDA. So counterintuitively, I think that the FDA can actually help facilitate the long-term development of these products and these markets rather than undermine it. And again, I think the goal here is to encourage high-value innovation and discourage low-value innovation, the kind of digital snake oil you see people peddling on the App Store, which is all too prevalent. So for years, scholars like me have been nagging the FDA to get creative about digital health and AI and machine learning. And to the agency's credit, it has. It's creative. We have a new framework that's been introduced over the past few years that represents what I think are 3 important experiments in medical product regulation. And again, these are important deviations from how the FDA typically regulates pharmaceuticals, medical devices, biologics, and the like. So first, the FDA is shifting its emphasis from pre-market evaluation and evidence gathering and testing and clearance to post-market evaluation, which should satisfy the critics that say that FDA regulation keeps technologies off the market. Second, the FDA is shifting the locus of its review from the product to the firm. Instead of going product by product and evaluating whether something is safe and effective for its intended uses, the FDA is trusting that firm-level characteristics will better predict product quality than product-level characteristics. And this is an important shift. Can you imagine if the FDA just said, every drug Pfizer sends to us will get a streamlined pathway to market? And finally, the FDA is experimenting with third-party certification and decentralized reviews. So what I've done is, having kept track of the FDA's regulatory actions and its pronouncements, its guidance documents, everything it's said on the matter, I've tried to tease out what I see as the FDA's emerging philosophies so far. And it's hard to keep track of these things. The FDA, to its credit, is coming out with new announcements, new regulatory actions almost weekly. And so there's a lot going on here. So the first important thing I see happening is the FDA is making risk-based decisions. It's stratifying products based on risks. Now, this isn't entirely new. The 1976 medical device amendments in the United States tell the FDA to use a risk-based approach and to treat high-risk and moderate-risk products differently than low-risk products. And that makes sense, and that's entirely intuitive. But the FDA has become much more specific in articulating what that looks like with AI and machine learning. So they ask, what situations is the product used in? Is it used in critical situations, emergent care? Is it used in serious situations, or is it used in non-serious situations? They also ask how the product is being used. Is it being used to directly treat and diagnose patients? Or is it being used to drive clinical management? Or is it being used merely to inform clinical management and clinical decisions? So there are very real differences between those. And so this kind of matrix the FDA has developed determines what kind of pre-market submissions it expects from companies and how much regulatory scrutiny these products and these companies will receive. And this is smart because not all AI products present equal risks. On a related note, the FDA's philosophy is to consider how clinicians interact with these products. So for example, the FDA asks, will physicians and healthcare professionals have time to reflect on the advice being given from these software programs? And if there's going to be time for what the FDA calls competent human intervention. And this is not entirely new either. The FDA first articulated this principle back in a 1987 guidance document, where it says that clinical decision support programs that don't give time for humans to reflect on the advice and make an independent decision, exercise their discretion, will be given much more scrutiny than products that do. But again, we have things like automation bias and important advances in how we understand human-computer interaction that suggest this is an overly simplified way to look at things. Another important shift is a shift from pre-market to post-market, which I mentioned. In more recent documents, the FDA is emphasizing more of a total product lifecycle management approach, which is kind of a feedback loop in which it expects companies to continually evaluate the performance of their products and to continually improve them. So rather than relying on this century-old pre-market versus post-market bifurcation of evaluation, the FDA is expecting companies to continuously evaluate these products because that is possible. A related idea here is to focus on the firm and not the product, and so this is the FDA's pre-certification program where it will try to identify companies that have a culture of quality and safety. Do they have robust quality assurance programs? Are they engaged in this continuous product lifecycle management approach? Are they continuously improving their products, identifying errors and shortcomings? And this is relatively new. The FDA has articulated principles in the food space regarding continuous kind of life cycle quality management, but never before in medical products. The FDA has also articulated some sophisticated and I think nuanced principles on clinical relevance and validity. So the FDA says it's going to look for valid clinical association. Does the software output, do the recommendations and information relate to some targeted clinical condition? It also looks at analytical validity, how accurate and precise and reliable is the program? Does it generate reliable results when tested and challenged? And then it looks for clinical validation. How relevant is the program to actual clinical care, the care that physicians and hospitals are providing? So the FDA says in this document that it might require new data from companies, i.e. clinical studies, and companies might be able to rely on existing data depending on how mature the evidence is. So is an AI program improving an area of care where we have lots of data and we know what best practices are, or is it diving into some novel therapeutic area or using some novel therapeutic theory to treat some disease? And so again, I think this is a very nuanced, flexible approach that we should commend the FDA for exploring. And finally, one challenge, but one principle the FDA has identified is ensuring that these algorithms are relatively transparent and auditable. Can they be audited? So if you look at the other bullets above, a lot of those things won't work if these programs are truly black boxes, if they're truly opaque and not amenable to review and validation and the like. So how are these things manifesting themselves so far? How are these principles manifesting themselves? So last April, the FDA approved a de novo submission, meaning kind of not a 510K where a product is arguing that it's substantially equivalent to something already on the market, nor a PMA, a pre-market approval, where you're going through multiple stages of clinical trials. This is a de novo submission for a product called IDX-DR, which diagnoses diabetic retinopathy and vision loss in patients with diabetes. It's one of the leading causes of vision loss among diabetic populations. So the software uses AI to offer a diagnosis. Either you have more than mild diabetic retinopathy or you're negative for that. And the study of 900 patients detected 87.4% of all positive cases and 89.5% of negative cases correctly. And the provocative thing about this technology is it removes the need for referral to a specialist. So doctors that treat diabetic patients but aren't themselves eye experts can use this program to refer to someone to get treatment, hopefully early enough to have a meaningful intervention. And so again, the FDA approved this product, it cleared the product for use by primary care doctors. Likewise, last February, the FDA approved a de novo application for Viz AI Contact, which analyzes CT images to detect strokes and immediately alert a neurovascular specialist. And so here's an article in Wired that nicely explains that when patients are having a stroke, time is everything. Timing is everything with the stroke response, and the program relies on AI and machine learning to send automated messages to response teams to increase the response time, which can mean everything for stroke. And it was supported, the evidence was supported by a retrospective study of 300 CT images comparing performance against 2 trained neuroradiologists. And so the company used both real-world existing data and clinical study to show that it did improve actual response time. So again, there's some meaningful connection to clinical care. Colleen mentioned yesterday Arteris, a self-teaching neural network that measures ventricular function, which can achieve in a few seconds what would normally take a physician up to 30 minutes to analyze. We have other examples which have been mentioned before, the program at Stanford using deep neural networks to detect moles and the like. So the FDA's approach is novel in many respects, but it's not entirely unprecedented. 20 years ago, scientists started discovering hundreds and thousands of genetic biomarkers that might correspond to disease, but we weren't sure of their clinical significance. We didn't know if having some genetic variant necessarily meant you were at higher risk for disease or not. And so what the FDA did with the National Cancer Institute is it set standards for incorporating biomarker studies into early phase clinical trials. And the standards looked for biological plausibility, analytical validity of the assays, et cetera, et cetera. So there's a recent article in Science that does a wonderful job of using this example as a way we might extend similar principles to artificial intelligence. So I'll leave you with this notion. Sorry, the text is different. How would these technologies develop without some sort of centralized regulatory review? What evidence would developers and companies generate? Would that evidence be public, that the products work as intended? And would we be able to rely on it? And how would the market function if there wasn't an FDA, if none of these products were subject to FDA review? Well, I think most of you can probably suspect my answer, but here is something I saw in the MIT Technology Review last month. Up to 40% of DNA results from consumer genetic tests might be bogus. And so, again, companies like 23andMe have been under some scrutiny. 23andMe tried entering the health space and ended up taking its health diagnostic tests off the market after the FDA said these aren't valid, they're not reliable. And so I propose that this is what the market might look like for health AI applications without some centralized regulatory push and pull. Thank you.
Nathan, so I'm looking over at Colleen. We started a little late. Can we take a 5 minutes extra? Yeah, okay. So let's have some, so we have time for some questions. So there are 2 microphones, but if you have a really loud voice, you can also just stand up, I suppose. But maybe you want to go to the microphone that's close to you. Tell us your name, where you're from, and then please ask your question. So we have a question over here.
Caitlin Gillen. I'm a radiation therapist and PhD student in Toronto. And my question, I think, is specifically for Vanessa, but if anyone else has some insight, I'd appreciate it. So I really liked what you were saying about the regulatory colleges and setting practice standards and education. But I think there's also a very nuanced but distinct difference between the regulatory bodies and the professional association. So if the regulatory body's primary responsibility is to protect the patient, then there's the professional association. So if you think of something like the Canadian Association of Radiologists, what is their role in determining where AI can take over some of a task and where it has no business being, and what that's going to look like in terms of protecting the quality and safety of the care we deliver?
That's a fantastic question, and we've actually seen the professional associations being a bit more active, actually, than the regulatory colleges. So the Canadian Association of Radiologists, as you said, they have struck a task force. They have a couple of white papers out in terms of what to do about privacy, how we should think about liability, these types of things. The Canadian Medical Association's done some work on this as well. I do think the professional associations are, are well placed to do some of this work, but that shouldn't, they have a complementary role to the regulatory colleges. It does not let those colleges off the hook, so to speak, in terms of developing that expertise in-house. So I think that's the quickest way that I can answer that. And I think the professional associations, certainly in building the expertise up at the college, could be involved in assisting the colleges to do so, to the extent that they've got experts and have thought carefully about some of these specialty-specific issues. Their expertise can be really helpful to the college in terms of setting those standards, doing education and training. Much of the education and training that's done by the colleges is actually done in conjunction with the Royal College of Physicians and Surgeons or with the association. So I think there's a nice complementary role, and I'm glad you highlighted that. Thanks.
Good morning. Good morning. My name is Antonia Maioni, and I'm here from McGill University, where I'm a political scientist and also a member of the research group in health law. I think the way this panel was set up, I'm not sure if you want us to vote at the end, because each one of you presented arguments for a different type of regulation. So I'm going to vote. And I'm going to vote by saying the first demonstration of the regulation, by thinking about this as a roving expertise group or a think tank, makes me think of, the economists who are blindfolded and trying to figure out the elephant is. I'm sure that's a good way of thinking about getting experts together to try to unpack some of these issues. But I'm wondering if that alone will give us the kind of regulation that we need. As for professional self-regulation, I think some of the question, you've just answered a question that brings that to light. We can't even get electronic health records to be sort of something that people agree on how it would work and what it would do. So I'm not quite sure that professional self-regulation gives us the kind of regulatory framework that we need and the speed at which we need it. I think that's the other problem with the idea of having self-regulation in this particular frame. So I'm going to vote for the FDA model of regulation, and I'm going to say that the arguments that you presented really strike home about why, what some of your colleagues were saying about how in this area, the questions about privacy, the questions about safety, and indeed the questions about equity cannot really be left to either only experts or only self-regulation. Thank you.
So if I may, I think it's a false dichotomy to suggest that Nathan and I disagree. Indeed, the whole point of what I'm saying is that the FDA should remain, for most aspects of what it's doing, the prime regulator. The idea is to strengthen it, if anything, by offering it a core of experts it can call on at will. And hopefully not at a cost to it, which then makes it attractive to the bureaucrats to do that. There are a lot of other agencies that don't have nearly as much expertise as the FDA. I mean, they're actually ahead of, they and NHTSA are ahead of most of the others. So there are places where there's ignorance. And there's no budget. AI experts are rare and they're expensive. Very expensive right now, if you look at what the bidding wars are on. So I think that it's a completely false dichotomy in that sense, except in the small number of areas that I picked on. I mean, so if you want, for example, issues of data quality and control. And I'd love to know what Nathan thinks about that, because the FDA has spoken to that some and said things that I find weird. Right? I mean, so the FDA is, for example, suggesting that you do an ML project with a database, and you change the data, as long as you sort of promise them it doesn't change anything major, go right ahead. That's weird.
Yeah, I would say the same. I'm not suggesting that we not have a regulatory framework like the FDA. I think my message is that I think the colleges can't ignore the role that they're going to have to play in regulating. They're an important piece of the regulatory landscape, but absolutely should not be the only regulator of AI in healthcare. I want to be very clear about that, if it wasn't clear at the outset.
Yeah, I'll just make a very quick point that the challenge here is that we're dealing with a technology that doesn't fit into traditional regulatory buckets. FDA in the US regulates products, states license physicians, the colleges oversee ethics, and so is AI a product? Is it a service? Is it professional service? And so we're stuck with a really 20th century regulatory scheme trying to address things that were just beginning to be contemplated back then.
So it's terrific. We have a number of questioners at both microphones, so if I can ask you just to keep your questions brief and answers brief as well, so we can get as many as possible. Next question, please.
Okay, so I'll try to honor that, and then maybe partly I just want to say something, but I do have a genuine question, but I'm going to say it first. So I'm going to make the case that health AI is different. I'm Alison Paprisa from the Vector Institute for Artificial Intelligence. And I'm going to say it's different because the risk of inequity or harm at the individual level, literally life or death, is different than the risk of an airline going down. And so, for example, if I transfer an adult-developed device to a pediatric population and children are harmed, that's different than an insufficiently regulated financial institution. And in a publicly funded health service like we have, people don't actually have the choice. If a model gets adopted by a hospital, they're just going to get it. So I do think health is different. Notwithstanding that, I really like the idea of starting with the sectoral regulation. Why would we not make use of that? And having some sort of body that are experts in the technology that advise, not just health, but other ones. And one of the reasons I like it is for what I would consider the secondary benefit, that it creates a place where the learning can happen. And so this is my question. If there's not time, you don't have to answer it. But one thing I'm not hearing, and I actually believe we need, is a deliberative discussion about where do we start. We are not going to simultaneously have regulation for everything from an app to a device that's life and death. And we actually have this sort of interesting category that are critical and serious, but the truth is the AI is all about benefit. So for example, if an AI system can capture swirling data in a way that a human never could and predict someone in an ICU is going to have a heart attack 5 minutes sooner, we want that. There's no downside. They would still have the heart attack 5 minutes later if we don't detect it, but we want to be making use of that. So my question is really about, do you agree that we need to sort of be very deliberate about where we start? And I would say, in a way that doesn't necessarily have a path to commercial benefit as its primary goal, right? This shouldn't just be responding to companies and what they happen to be able to offer. That's sort of my question. Should we be deliberate about where we start so that we can learn and spread?
So I'm conscious that I'm in Canada, and therefore I would disagree very politely. but very politely, I very much disagree with your priors. Here's an example of how health is not different. If we use AI for sentencing, or if it's within a country the death penalty, it's life and death, or it's your life in prison, it might as well be life and death. If we use it to inform police, and this is being done in market, is the potential dangerousness of inhabitants of a house at which they are trying to decide whether to knock politely or arrive with guns drawn and a SWAT team. Those are issues of life and death. Certainly in the United States, where there are a lot of guns. So that, in fact, we have life and death in many other non-health AI applications. I know it's a tough sell in a crowd like this, but health just isn't as different as you think.
And let me just, if I could address the point about institutions incorporating AI. There's a scathing report by the University of Texas Board of Trustees that looked in depth at how much money MD Anderson Cancer Center spent on Watson, IBM Watson. And the company had made all these promises. We're going to offer customized treatment and diagnostic recommendations based on all these all these clinical data sets. And the Board of Trustee report said you spent $80 million, like some ungodly amount of money, and they got almost nothing for it. They abandoned the project. It got a lot of media coverage. And MD Anderson is a sophisticated purchaser. So if they can't, and that may be an unfair example because it's so early, but if they can't decide whether it's worthwhile, how is the individual downloading an app going to decide? So I don't know. It's a tough question. Who should do what and when?
So unfortunately, we have time for one more question. So apologies to those of you who are still at the microphones, but let's have our last question.
Hi, my name is John Anderson. I'm with the Professional Institute of the Public Service of Canada, which is a major federal government union, and we represent doctors, nurses, and other health professionals with the federal government and with some, actually one territory as well. So we're concerned with this. I liked all three presentations because I don't see that there's a contradiction. I think it's a question of putting that package together of regulation. And I would say on the sectoral thing, I'm very, having worked in the past with sectoral councils in Canada, which were abolished, but the government is thinking of bringing them back. This would be something that the sectoral councils could do, actually, which they represent business, labor, etc., on these sectoral councils, and this could be something that could be added to that regulatory framework. I just wanted to add that I think that we have to, in the broader regulatory framework, because this is such an important transformation which is occurring, we have to add both community and labor into the mix. And I find that, we've got to find a way of getting them in there, because when we're looking at AI, if it's changing the way that the health system is delivered, we've got to have a role not simply for professionals, and we're professionals, so we want those professionals in there, but we also got to have a broader role for employees in the health sector who are not professionals, number one, but also for the communities that are affected if we change the way that the health system is, or health policy is delivered. We've got to find a way of how to, what say does community have? Because it's not simply an individual issue. It's an issue, some of these changes in artificial intelligence will affect a much broader way that health is administered. So I'd like your opinion on that.
Any closing comments?
Just very, very quickly, I mean, one model says it's on. One thing that some people who write about this worry about is de-skilling of doctors, right? That there'll be a transfer of the work from the doctor to the machine, and the consequence will be more work for technicians who will wire up the patient with all the sensors and feed all the data in the machine. I don't know enough to know if that's where we're going, but it's certainly a plausible story.
Okay, so that wraps up the first panel. I want to ask you to join me in thanking three terrific speakers.